Okay, so we've just ticked over to 1 o'clock, so we'll make a start with our slides. We're recording this session, so if you don't want to be on the video, as it says there on the slide deck, please turn your camera off. And also, if you could please mute yourselves as well. We will be asking whether there's any questions, etc., at various points and towards the end of the presentation. So you will get a chance to ask any questions that you've got. I just want to do a quick introduction for you. My name is Becky. I'm the Diabetes Project Manager for the ICB, and I'm welcoming today Harry McMillan, Catherine Brown and Nikki. I can't see if Nikki's on the call yet, from the provider Momenta Newcastle. Now, Momenta Newcastle are the provider for our type 2 diabetes remission service, which is an NHS funded programme, so we get a number of spaces to fill each year. And this provider has been delivering this across other areas, and so is quite confident with delivery. And they're going to be giving you some information during this session on how you can actually make referrals into the service, what you need to do as GP practices, and then some more information about what your patients will get and medication adjustments, etc. I'm just trying to move this on. So essentially, this service is for type 2 patients who need some help losing weight. So that's it in a nutshell, really. I've just explained who Momenta Newcastle is, and the role of general practice in this programme will be discussed kind of a bit later on during the session. So we're going to focus on the programme first, and then we'll move on to more of the medication section towards the end of the webinar today. So I'm going to hand over, is it you, Catherine, first? Or is it Harry?
I believe this is going to be Harry.
Me, it's Harry.
Harry.
Yes.
Yep.
Okay, I'll pass on to you then, Harry, for you to kind of go more in depth about this programme.
Thank you, Becky. Nice to meet everyone, and apologies for my slight strange backdrop. I had to join my mobile rather than computer, as Teams isn't working. So in terms of the background to the program, the type 2 diabetes remission program, it's based on research. So primarily the direct and droplet studies, which showed that remission of type 2 diabetes was possible in primary care at scale. In the direct study, at 12 months, the intervention group, 24% had lost 15 kilos or more, which was a significantly greater number than they'd been anticipating. And almost half achieved remission, of whom about 70% retained remission at 24 months. And there were fewer adverse events in the intervention group than the control group. Remission was closely linked to weight loss, almost a straight line, in fact. And remission in this case is defined as having an HbA1c of less than 48 millimoles per mole for more than 6 months and on no medications. So in some cases, as we get on later on in this webinar, you'll find that it won't be possible for some of your patients who are on multiple medications to meet this definition, but they can still get many of the benefits of the service and of the weight loss. As far as the benefits are concerned, from a patient point of view, there's obviously significant weight loss as a possible outcome for most, if not quite all, but certainly most. The possibility of remission, a significant reduction in their medications, both for diabetes and also some other medications, potentially around blood pressure and others. There's a positive impact on comorbidities that are related to both diabetes and excess weight, and also an improvement in healthy living and quality of life. The entire program is free. That's a significant benefit, particularly for people impacted adversely by cost of living, as most of us are, in fact, but particularly for those in lower income areas. And there's some case studies on that link, and you'll get the slides later. From a practice point of view, the service is free because it's, I say free, it's commissioned by NHS England. All eligible referrals.
So come down from Canada.
All right.
I don't know if she's sat.
Someone's popped off mute. Would it be possible to go back on, please, if you're not speaking?
Isn't this working?
Becky, I don't know if you can see who it is. Thank you. The referrals are eligible for the weight management enhanced service fee of £11.50. And anecdotally, and possibly most importantly from a practice point of view, but very difficult to quantify and provide hard data on. There's a strong view that this service reduces the demands on practice for successful participants for all the reasons mentioned above, and we provide extensive support. So as far as the framework of the service is concerned, the NHS England approach has been initially to pilot it in 20 ICBs from 2020 onwards, and those pilot ICBs have found very similar outcomes to direct, and they've now commissioned a national framework with a bit like the diabetes prevention programme, of whom we are one of 5 providers. They changed the name from the NHS Low Calorie Diet to the NHS Type 2 Diabetes Path to Remission programme. And the design now under the framework is very similar to direct. So it's a one-to-one service. The difference is that it's a choice, patient choice of one-to-one in person or one-to-one digital. And it's jointly commissioned with the ICB. As most of you don't know who we are, a very brief background on Momenta. So as well as being the provider in LLR, we've been delivering this service since 2020, originally in Birmingham and Solihull, and then gradually in more ICBs, now up to 13, or we will be in 13 by April next year. And our early outcomes are also in line with the national framework and with direct, and that's 11 to 13% weight loss at 3 months, maintained into phase 3. There's very positive uptake of eligible referrals, and it appears to be helpful from a health inequalities point of view. So where we have the data, we've seen some very significant levels of referrals from across ethnicities, across IMD postcodes, IMD quintiles, etc. Okay, so on to a little bit about the program itself. As we said, it follows the principles of direct. It's delivered by our trained coaches. There are 3 phases over 12 months. And the fact it's a 12-month program is really important to emphasize. It's not just the 3 months phase 1 of shakes and soups and other products, low-calorie products. That's the most intense phase and what it was sort of known about, what's widely known about this service. But it's really important to get the benefits that patients stick with the program through the structured food reintroduction, which is reintroducing 1 main meal every fortnight over 6 weeks, and then into the weight maintenance phase, which lasts up to a year. And that basically reintroduces, or for some, introduces healthy eating patterns. We talked about delivery format, and as Becky said, there are 500 starters available in LLR or across LLR over the 2 years. NHS England have indicated there might be some flex to increase that if referral volumes, if you bust the limits on referral volumes, which we will be delighted to see. From an eligibility point of view, I won't go through all of these criteria now because you have the slides and they're also on the referral form and in the medication guidance. But I've just highlighted the ones that are probably the areas where we see most people refer to us that are not eligible. So the first is that there's an upper age limit of 65. So it's adults only, upper age limit of 65, so different from the NDPP. The second is, although it's a diabetes remission service, and obviously therefore patients have to have diabetes, type 2 diabetes, they must have been diagnosed within the last 6 years. And NHS England are very firm on this. So 6 years and a couple of weeks is still outside the cutoff, unfortunately. And then the HbA1c limits are, as you'd expect, if they're on diabetes medication, then it's 43 or above. And if they're not on diabetes medication but recently diagnosed, then it's 48 or above. And there's an upper HbA1c limit of 87. And again, they're very tight on this, all with a measurement within the last 12 months. On the exclusion side, the biggest one that you might not anticipate is, well, you probably would anticipate, but might not be immediately obvious, is insulin is an exclusion criteria. And then other than the specifics in the middle, which are quite clear, and I think if you look at those in more detail, you wouldn't find anything particularly unexpected. It's also important to mention the bottom point, which is the health professional assessment. So if you do not believe that your patient would be able to either follow the program, the effect prescription of 3 months of total diet replacement products, and or it's not possible to monitor their medications and adherence to it safely, and their monitoring measurements, which we'll come on to in a minute as to what we ask them for if they're digital, or we check if they're in person, then it's important that they are not referred. And if there are medications you're unsure about, then it's also important to either double check or again are on the side of safety and not refer. We have seen some things which are not in the exclusion criteria, but which are strongly associated with a lack of success. And again, as you'd expect, given the 3 months of total diet replacement, that includes anyone with significant sort of gastrointestinal issues such as IBS or other intolerances, because there's quite a it's quite a significant dietary change for the vast majority of people for the first 3 months. So I think it would be important to just make sure that they're very aware of that, and that it will be not as straightforward for them as for others. Okay, so in terms of the sessions and resources, again, I won't go through this in huge detail, but you can see the 3 phases there quite clearly in colours, and the titles give an indication of the focus. So the focus of the first phase is sticking with the TDR. So unlike some typical weight management programs or diabetes prevention program, for example, the focus is very much on the behaviour change up front. And then in the third phase is where the healthy eating really kicks in, healthy eating advice. Physical activity is introduced from phase 2 onwards. As far as the meal, we provide a lot of resources. It's slightly different for the in-person than for the digital. Digital obviously receive an app. As far as the meal replacement products are concerned, there's a very wide range available. We use ex-ante products, and participants order with a voucher code. They order directly. We provide support if required. Most people don't require it, but where they do, we can support that. They get free next day delivery, and they order in tranches, so a month at a time, basically. There's vegan and other options available, so we have had very few people ever have any challenges with the product range. Again, we've catered to a wide variety of ethnicities and other and religions, and obviously the products are all free. The participant resources, just to give you an idea, we try to look after your patients. We give them lots of well presented resources which are easy to use and interactive for the in-person program, and similarly for the app. They also get a pedometer, a little wallet reader and a label reader and stuff like that. Moving through onto the actual roles and responsibilities and referral pathways part, so I guess the most interesting part possibly, apart from the medications adjustment. So what we've done here is show the GP practice responsibilities and ours. Ours are in blue and yours are in grey. Obviously, yours are fundamental at the beginning. Without any without referrals, we can't provide the service. I'll come back to the language question in a minute. I just saw that pop up in the chat. Thank you. So the service is reliant on your referrals. And they can be done in a number of different ways, and we'll come on to that in a minute. We try and provide as much support working with the ICB as possible, whether that's patient information, referral forms on PRISM, etc., as well as drop-in support sessions and these kind of sessions. After you've made the referral, we look after them on the service. Obviously, it's distinct from their normal care, which remains in your responsibility. And your only requirements are to do an HbA1c check at 6 and 12 months, and potentially a medication review, either on discharge for sure, or if we alert you that the monitoring results are above or below certain NHS England thresholds, and then we will let you know if they need a medication review and whether that's it's time sensitive or not. We'll obviously also inform you of any significant side effects or adverse events. As far as the service is concerned, Once you've sent us a complete referral form, then we will do a registration call with your patients and an individual assessment. We go through the description of the service in a bit more detail. We make sure they understand it, and we give them the choice of the in-person or digital. Once they've made that choice, they can't then change, unfortunately, but that's just part of the spec. Then we start the first, second, and third phases. And during those phases, we make sure that you'll be glad to know, we're monitoring not just attendance, but also weight and blood glucose, finger prick test, which we supply all of the resources patients require. Also blood pressure for those on blood pressure medications at referral, as well as monitoring for side effects and adverse events. If those, particularly blood glucose and blood pressure measurements, fall outside the thresholds, as I mentioned, then we will alert you. There's a kind of intermediate threshold, which is they need to fall outside that at 2 sessions in a row, and the more extreme threshold, we contact you same day and advise them appropriately. Now, we monitor those readings at every session or session equivalent for the digital participants. They start off weekly, and then they move to fortnightly partway through the TDR phase, and then they more or less stay fortnightly until the third phase when they move to monthly. There are some subtleties, but that's the gist of it. As far as referrals are concerned, if you can cluster referrals that you send us, that's helpful, because for the ones who want to access the program in person, the more we have in a given area, the easier it is and the quicker we can put a clinic on to accommodate them. But that's nice to have. So there are 3 basic approaches to making referrals or identifying interested patients. The first is to do a register search, and then send them out an invitation, which would signpost them to a landing page, which we will give you details of, or you can attach a PDF flyer. The second approach is more of an opportunistic approach. So that is if you're having appointments or on, whether it's a diagnosis or annual review or a medication review, or possibly even at patient request. And the third is a more bespoke approach. So if your practice or potentially PCN is particularly interested in doing maybe an event for interested patients, then we can work with you and support that and attend that with you and share lessons learned in other places, and we'll support that with the ICB. As far as the question about languages was concerned, the materials aren't currently available in other languages because the volumes of the service are fairly small, at 250 a year. So it's just not practical to translate it's not cost effective to translate the level of the materials into different languages. However, having said that, we can and have worked around that issue in various different ways. So some of our coaches speak other languages, and particularly for digital participants, they're more available because the digital participants, although they are supported by the app, also have regular coach calls. The other way of doing it is if you have a particular concentration in a given area of patients who speak a particular language, then we can work with you in the way that Becky's just put up in the chat to make sure that there's translation available. Thank you, Becky. That's a shortcut, that description. Right. So this is just an example of the patient information. So we have a basic poster for practices to put up to raise awareness of it. And then there's a flyer, again, double-sided A4 for ease of distribution. And that flyer can be also sent via PDF and is available electronically in a simpler form without the graphics, so it's easier to read online at that link there. As a patient landing page, which can also be sent in text invitation or information invitations. So Becky has sent a copy of those to you, and will potentially send some more to you next year. But your practice will have received some of those. Okay, so that's the overview of the program, and now moving on to the medication adjustments piece. So this is once you have identified interested patients and you are you're talking to them and they've expressed an interest in the program, how do you go about the medication adjustments? So the rationale for deprescribing both of blood glucose and blood pressure medications is here. This data comes from the counterbalance study, which was a precursor to DIRECT from the University of Newcastle. And you can see in the chart on the left how blood glucose drops extremely sharply after the commencement of a very low calorie diet. Blood pressure drops, not to the same degree, but also drops. And it's important to say that those drops were seen despite patients in counterbalance and DIRECT stopping all of their blood pressure and all of their blood glucose lowering medications. The protocol in this program is more conservative than that, so less risky. So we're going to spend a little bit of time on this because deprescribing is a little bit less familiar to most people than prescribing. That you'll be delighted to know, in addition to this, there's a very comprehensive set of NHS England expert reference group guidance, which is on the website, which we'll give you the link to at the end. The guidance is all designed to be safe, evidence-based and pragmatic. As I say, it's more conservative than DIRECT. And really importantly, the clinical responsibility remains with the referring GP or GP practice. So if you are not confident in referring or in medication adjustments, then you should look at the guidance in more detail. And if you're still not confident, then the best decision is not to refer that patient if you don't think it's possible to do so safely. So none of the guidelines replace your clinical judgment. On the glucose lowering agent side, you'll see on the left, the first one is if your patients are not on any agents, then you can just complete the form and refer them directly. You'll still need to complete the medication adjustment form, but just the top section to say they're not on any relevant medications. Because if that's not complete, unfortunately, according to the spec, we can't accept the referral. So we'll have to send it back to you to ask you to do it. So please do complete even though just those top sections. But for those patients, they're the simplest variety and need no deprescribing, obviously. If they're on 1 to 2 agents, it's also pretty straightforward. You stop both of them. If they're on 3 or more agents, then you should retain metformin or the first-line agent if metformin is not, is contraindicated. And it's very important to make sure that you absolutely stop any sulfonylureas, SGLT2s or meglycinides because they are contraindicated for a low-calorie diet for obvious reasons. So in basic form, 0 agents, don't do anything apart from fill out the form. 1 to 2 agents, stop both, fill out the form. 3 or more agents, keep them on metformin or the first-line agent, and absolutely stop the ones that are contraindicated, which we'll come on to in a second. And also counsel the patient about osmotic symptoms and seeking support if they come up. And then send us the form, and then we can start. If they're on insulin, as we said, that's an exclusion criteria. And the final thing is to say that you should please make sure your patients understand they're not to make these changes until the first day of starting their total diet replacement products. So the first day they start the products is when they should make the changes, not beforehand. Okay. Just in terms of the safety of glucose lowering agents, we've talked about the 3 that are not safe. NHS England obviously prefer you to deprescribe GLP-1s as well from both a cost and an availability point of view, but they are safe. It's just that they are obviously expensive and scarce. Okay. In terms of if your patients, the blood glucose monitoring exceeds those thresholds that we talked about. So Becky, if you go on to the next slide, please, you'll see if they are over 15 or in fact the HbA1c that you will do at 6 and 12 months increases, then you might want to restart certain agents. So again, if they're on no agents, restart metformin as the first line and continue that way. And there are other agents. Obviously, you must not restart the sulfonylureas, miglycinides, or SGLT2s when the patient is on TDR. And if you think they need to go onto insulin, then you should also, that's fine, but they must stop the program at that point. So that's the restarting agents. In effect, it's just in reverse. In terms of BP lowering agents, the first point is that these don't just relate to medicines prescribed for blood pressure. There are obviously other medications as well that lower blood pressure that that aren't prescribed primarily for that purpose. First point is, if their blood pressure is elevated, either systolic or diastolic, then don't change their medication. If their blood pressure is within range, then it's about first identifying the agents that are prescribed specifically and only for blood pressure, and then adjusting them by basically going one step back on the up titration. So the last one that was introduced, stopping that one, or reducing the dosage if you're unsure. Obviously, then counselling in all cases your patient if they have had elevated blood pressure, counselling them about postural hypotension, and how to seek support. We will obviously do the same, completing the form and sending it to us. And again, the advice is not to be very clear that they shouldn't make those changes until they start the total diet replacement products. So on day one, that's when they should make the change. If the medications are being used for other reasons, then obviously you don't want to stop them if that's going to have an adverse impact on the reasons that they're being prescribed. So only stop the agents that are prescribed for blood pressure and stop the last one. And there's a little indicator of which ones you should stop first, depending on where they are in the up titration. If they're on agents which affect blood pressure, but they're all being used for other things, then discuss it with the patient and maybe reduce the dose of one or possibly more, but talk to the patient about it so it's a very clearly informed decision. If then we tell you that the blood pressure is either too high or too low, if it's too high, it's easy. It's just increasing as per NICE guidelines. If it's too low, then it's repeating the same process you've just been through in terms of adjusting it. Just as an FYI, we tend to find that there are more patients who report blood pressure that is too low than it is too high, especially the ones obviously who are successful and losing significant amounts of weight. And that's even more exacerbated, as you'd expect in the summer, with despite all the advice we provide about drinking water and staying hydrated. But that's just in case you're concerned about deprescribing the blood pressure agents. We tend to see more people with blood pressure that is too low rather than too high. If that provides you any comfort. So finally, on the medication side, there's medications that might need adjusting for weight or dietary changes. This isn't, or the next slide won't be an exhaustive list, but it's important to take into account that some of these might not be ones that you've prescribed in primary care. They might be prescribed or administered by other services. So, but unfortunately, from this point of view, it's your responsibility as a referrer to make sure that those medications can be adjusted and monitored. And if it can't be done safely, then they shouldn't be referred. In terms of some examples, you can see there warfarin and DOACs are probably the most common, but there are plenty of others as well. These would not typically be adjusted immediately because you want to see if your patient loses weight, or they will be if they're impacted by the diet potentially, but not for weight loss. And then it's about just making sure the monitoring processes are in place. Okay, I think that's it on the medication adjustment side. Becky, back to you for the referrals, I think.
Thanks, Harry. I tried to get myself off mute. So I'm just going to talk about the local systems that we've got in place for you to actually make these referrals and to identify your patients. So obviously Harry's covered a little bit about the 3 ways that you can identify these patients. We can search, screen and invite them. You can do it opportunistically or kind of a bespoke model. So to help you with the first one of those, we've actually developed a a search in System 1 and EMIS, and that was actually shared on the LHIS message board. So you should have all have seen that, and there's also a guide available from LHIS around where to find those searches. So the search includes most of the it includes all of the eligible criteria. So the inclusion criteria is all on there, and some of the exclusion criteria. So what I would say is that it's quite difficult with some of the exclusion criteria that Harry mentioned earlier on to actually put those into a search. So it's really important if you're going to run a bulk search to actually sense check that really at a kind of local level. You know your patients, you know which ones are going to be suitable for this programme, and just kind of use your clinical judgment really. Obviously, opportunistically, if you've got patients that you think might benefit from this and you're seeing them for another reason in practice, it's an opportunity to just sound it out with them, see if it's something they'd be interested in. And then we've also got the kind of patient events that might pick up patients in the community that might be interested in this programme. So we would recommend that you have a referral appointment with the patient. So you could have an initial chat with them maybe, and that could be done over the phone or in person, whatever is most suitable for your practice and the model that you're working with. You might choose to do that at PCN level possibly, or individual practice level, but that's entirely up to you how you have those conversations. But it is really a really important part of this programme, because obviously the programme is quite intensive. It's a 12-month programme. When you make that referral, you need to be fairly confident that that patient is actually going to uptake this offer. So actually a conversation with them about what's involved, what the stages of the programme are, is really important before you actually make that referral. So the referral itself can be done on PRISM. So there's a PRISM form that's been developed, and that takes you through all of those eligibility criteria and also the medication adjustment section. So there's bits on there that you need to tick, and you need to sign off that you've actually spoke to the patient. So the PRISM referral form is quite easy to find on the next few slides. There's a few screenshots of where to find it. And then once you've actually completed that referral form and made sure that all of the information is on there, you need to then send the referral in to this email address. So all of that is on the PRISM form as well. And obviously, once you've got the letter that will go over to Momenta Newcastle, you also need to give the patient a copy of that letter. And you need to highlight that within there, the medication adjustment that you've talked with them about in terms of finishing their medication on the first day of starting this programme. So without that, the provider will not be able to accept that referral. They need assurance from the patient in the initial patient conversation with the provider that you have had that discussion about the medication adjustments. So if you provide that in writing to them, then obviously you've got a backup there. So in terms of the clinical system searches, LHIS added the post to their resource page on the 3rd of November. So if you're looking for it, that's where you need to go back to. There is also a support guide on there, and also there's a link to the EMIS import file for that search. So for System 1, the search can be found there as per this screenshot. So hopefully that will help you find it. So obviously on PRISM, it depends whether you're an EMIS practice or a System 1 practice. They both work slightly differently with the PRISM referral forms. So you can see there just screenshots of how they look on each system. This is the PRISM referral form for EMIS Web, because it's the only version I've got access to. I've not got access to the System 1, but I just thought it would be useful here to show you how the page actually looks. So in this first section here, it actually goes through the criteria, the inclusion criteria and the exclusion criteria. And it's more of a statement there than anything else. You don't have to tick anything at that point, but please do read that and make sure that your patient is eligible before referring, because Catherine will be at the other end of that email picking that up, and she will not be able to accept people if they don't meet those criteria. So it's really, really important that you double check before you send that referral in. The second part of the form is the medication adjustment. So here you can see that there's various tick boxes. So if they're on the SGLT2 inhibitors and various other medications, then they definitely need to be stopped, and you need to put a yes in that box. And then for the other medication adjustments, you need to kind of go through those and put a tick in each one of those boxes. They're all mandatory. Even if the patient's not on them, you need to kind of click a no if they're not relevant. And then the final page here is just kind of the covering options. It just kind of says, is the patient happy to be contacted by email, or would they like a voicemail leaving, etc. So it's patient preference, really. And then that's it. Your referral form will be complete. You can send it off. Catherine will pick it up out of the mailbox and process it. If there's any queries, she will be coming back to you to fill in any blanks. It's really, really important that you check the date of diagnosis is within 6 years, because that's the main reason things are being rejected at this point in time. I think we've got 73 referrals so far to the programme, which is not bad considering it's only been going till September, but of those 12 were not eligible. So it just gives you an idea of how many non-eligible referrals Catherine's getting through at the moment. So it is really important that you just double check that the HbA1c has been recorded on the clinical record and that pulls through into the letter that you're producing from PRISM. So just a kind of coverall really email with top tips for your searches and your referrals. In terms of the searches, sense check, manual screen to confirm whether they're eligible and the appropriateness of that. Looking at your clinical coding to make sure that the patient is eligible. And then you can do this in batches, and you can get your kind of admin staff to run the search for you. It doesn't need to be somebody clinical that's looking at that initially. And in terms of the medication and adjustments form, there's a few pointers there, which I think I've already probably covered the majority of that, and you will get this slide pack afterwards. So that's the kind of section that I was going to cover. I think I'm passing back to Harry for this one. Is that right? Yeah.
Yep, that's correct. I was thinking this was complicated until I attended a couple of your previous education sessions for other things, and then I saw that this looked like it was kind of, the noddy version, because some of the slides that you look at are vastly more complicated than this. So I felt better. Basically, this is just trying to put the most important information relating to the service in one place. I won't go through it all in detail because we've spoken about most of these elements. It gives you in the dark blue the kind of preferred approach of the search screen, sending the link and having the referral appointments and sending us the form. Or in the kind of aqua pale blue thing is the opportunistic approach. As we said, we can also do patient events at your practice or PCN level if that's helpful, but they're kind of a special case, if you like, and only if you're particularly interested or have a particularly relevant population. There's a couple of SNOMED codes on there. You'll see in the bottom left-ish, which are the ones that we can't tell you because we don't know if you've invited people or they've declined the invite. After you've sent us the invitation, or the referral medication adjustment form, then at every relevant point, we will write to you with the relevant SNOMED code that needs to be added as an action point. So those are the only two that you need to be aware of particularly, but we can't add. Our email address is there at the top, the top line on the bottom notes to send the referral forms to. There's a phone number if necessary for you or your patients. The landing page, just so you know, lists the phone number and also encourages patients to get in touch with us if they have any questions about the service. So we're trying to take as much of the load off you as we can, other than the actual referral itself and the medication adjustments. There are additional support sessions that we provide. There's a very long, these are all hyperlinks if you look at the slides electronically, but on the basis you might print them out, we've also put in the hyperlink. Not we expect you to type in that very long one, but the next two down below are a little bit easier. around the referral sources web page and the patient landing page. I think that's probably all we need on that one. And then as far as next steps are concerned, obviously immediately there's the Q&A and discussion, but we'd be delighted to help you. And when I say we, I mean particularly Catherine, but also any of us, to support you any follow-up if you've got any questions, whether it's around the program, the guidance, etc. Please tell your colleagues about this if they're not here or they haven't heard about the service, because we think we've been working in kind of lifestyle related areas for about 20 years in different areas of them, so less experienced than many of you obviously, and not as patient facing in some ways, but we genuinely think this is the most exciting service and the most potentially transformative for your individual patients, the right ones, for whom this is the right service and the right time for it. It's potentially really, really exciting. So we're very keen to spread the word. And as I said, we got drop-in sessions, or we can just set up meetings. We're very happy to come to other events. And the final thing, which gets onto the next slide, is that unlike programs like the diabetes prevention program, because the in-person sessions are one-to-one, we found that in quite a few areas where we've been working, there are practices that are keen for us to deliver the service to their patients, or potentially patients from reasonably nearby, in their actual practice building. So they might have a consultation room which we can put a clinic in for half a day or a day even. That can be really helpful. There's some very early evidence that NHS England were, not evidence, indications that NHS England were talking about a couple of weeks ago, which were saying that actually there's some indications that where people attend in practice, not only are there additional benefits for the patient and the practice, and that you can catch them for other things that you might want to catch them for, but also there are potentially better outcomes for your patients if they're attending in practice, which is really interesting. So we'd be very happy to talk to you about delivering the service in your practice. We won't take up too much time. It'll be very neat and all of that sort of good stuff. But if you think it's helpful for you or your patients, we're very happy to. And those are the criteria there. And then this slide just has all of the contact details, some of which have been scattered, or most of which have been scattered throughout the presentation, but just on one page. And it also has Becky's email and Jeremy's email. And from our side, your key Delhi contacts will be, Catherine will be your key Delhi contact, and also our Becky to go with your Becky, who is the contract manager. And then obviously myself as well, but you'll probably get more relevant information from Catherine or Becky. Okay, I think that's it from us, isn't it, Becky?
I think so, yeah. Thanks, Harry, and thanks, Catherine, for being here. It's probably a good time to open up to any questions. I've noticed that there is one question in the chat around the number of spaces that are available on the programme. So across the 2-year contract that we have, there's 500 spaces that have been allocated to LLR by NHS England. However, what I would say is that they are encouraging as many referrals as we can get in. So that's the message that I want to give you today. Don't think about the numbers, just make your referrals in. If you've got eligible patients, just do it. And we'll deal with that with NHS England as the need arises. So that's answering that question. I've just seen one from Farjan in the chat as well. Could this ever be rolled out for patients without diabetes for weight loss? Good question, Farjan, and one that probably we can't answer at this point in time. I think this is early days for this programme in LLR at the moment, but certainly if we see results from it, then it's something that we could potentially cover in future and kind of look into in more detail. Good question. Has anyone else got any questions? Feel free to put your hands up or pop them in the chat if you've got anything. Don't think I've missed any from the chat. Hopefully. Everyone's
Just
very quiet today.
One related point to the weight loss one, Becky, which is that obviously given the GLP-1 shortages at the moment, this can be potentially something interesting for patients who are worried about their GLP-1 supply, or you would otherwise previously have thought of prescribing GLP-1s to if they're not available, so or less available. So it's just something to bear in mind. We've seen probably an uptick in demand in other ICBs as a result, almost certainly directly of that.
Okay, thanks, Harry. I can't see any other hands up or any questions in the chat. So I'm assuming that everyone is kind of clear on the programme and that we can rely on the people who've attended today to kind of pass the information along to relevant colleagues in practices to get this programme really moving over the new year. Obviously, January, February is a great time for, new start. And this programme kind of ties into that. So the provider is very keen to get as many referrals in before that time as possible so that they can start running the face-to-face sessions. So any support with getting those referrals in prior to Christmas, I know you're all very busy, but if there are particular patients that you kind of can think of, or you're prepared to run a search and get those done now, then we would appreciate it. So just looking at the chat, when will we get material to discuss at practice meetings? So following this webinar, I will actually send out an email with all of the information we've discussed today, Basil. So thank you for coming. Any other questions before we wrap up? Sounds quite clear. Let's see how it works out with patients. And yeah, January, February is a good time. Good to see that you're thinking along the same lines.
Exactly, and I would just say to Sam's comment there that bear in mind we have to register the patients, check eligibility, and go through an individual assessment before we can start them in the program. If they're digital, they can then start basically immediately after that in terms of having the app and then receiving their products, which still takes a few days. So actually we find, and they've got a book there called The Coach and stuff. So if people are thinking of a January start, early January start, then it would be important to refer them this side of Christmas, and ideally, sooner rather than later. If they are also going to want an in-person clinic, then the more notice we have of that, or the more people you can refer at the same time, the easier it is for us to put those on. We will put them on for small numbers, but we still need more than 1 or 2 people in an area, ideally.
Great.
Thank you.
And I'm going to end on a piece of really, really good news for you all. Just to say thank you for attending today. I'm going to be sending you a certificate for your CPD, so that you've got that to show that you've actually attended this session today. So hopefully you're all over the moon by that. The recording of this meeting will be available, I think, on Momenta's website at some point in the very near future. So if you have got colleagues that want to listen to this training and haven't been able to get here today, then I'll be sending the link out to you shortly. Thank you all very much for your time. We've finished 10 minutes early, so you can go and have a cup of tea and a little bit of a break before your next clinics. Thank you very much.
Thanks very much.
Take care, everyone.
Thank you.
Cheers. Bye-bye.
Thank you.